Good morning, good day, and good evening. On behalf of the Interagency Working Group on Reproductive Health and Crisis, IAWG, the Sub-Working Group on GBV, and the GBV Area of Responsibility Community of Practice, we are really pleased to invite you to this webinar on clinical management of rape and intimate partner violence. So my name is Maria Holtzberg from the IPPF Humanitarian Hub, and I co-lead the sub-working group together with Daphne Evans from Emory University. The GBV AOR Community of Practice is co-hosted by Sarah Martin and Beth Van. So we highly encourage that you join these two groups and are really happy to be connecting on this webinar together. Before we introduce our guests and go into the presentation, just a couple of small points. Please be on mute. We will have a possibility there will be a possibility to ask questions either in the chat or openly, but when you're just listening, please be muted. The webinar will be recorded and placed on the IAWG web page, as well as circulated to both working groups. And we will start the session with a presentation, and there will be a section for Q&A. There's also going to be a scope for discussion embedded in the presentation, I understand. So just to introduce and set the stage, we're incredibly lucky to be joined by Elizabeth Roesch from WHO and Ann Burton from UNHCR to talk us through the updated guidelines on clinical management of rape and intimate partner violence. Elizabeth is the GBV and Emergencies Advisor with the WHO Emergencies Program and manages a program to strengthen the health response to GBV, both within the health coordination and health programming in crisis and conflict. Ann is chief of the public health section in UNHCR. We also would like to acknowledge Nadine Cornier, the humanitarian advisor on reproductive health for UNFPA, who is also part of this presentation and the work, however, currently deployed to Mozambique. The floor is now, I leave the floor open to Elizabeth and Ann. Just wanted to ask you to tell me when you want me to move the PowerPoint. So without further ado, I leave the floor open to you, Ann and Elizabeth. Welcome.
Thank you so much, Maria. I'm here in the same room with Ann, and we're very pleased to be presenting today some updated guidance on clinical management of rape and intimate partner violence survivors. So just to give you a sense of what we're going to cover in this webinar, perhaps you can go to the next slide. There we go. There are three things that we're going to talk about today. One, just some background on the clinical management of rape survivors guidance. So what is the history of this kind of key piece of guidance for the health response to GBV and emergencies, and what has been our process for updating it? If you've been hearing anything from me in the last year, you know that this has been on the way for a bit. So we're really pleased to be coming to the final leg of that journey and sharing some of the key updates with you today. The second thing we're going to look at is what's in the new updated clinical management of rape and intimate partner violence survivors. So already we're going to talk a little bit more about how we've expanded the guidance to include new guidelines and recommendations that we have that are really important for the humanitarian sphere. So we'll do a kind of chapter by chapter overview of what's in the updated guidance. And then finally, we're going to go into next steps. What's the plan for dissemination and rollout? When can you expect to see hard copies and in what languages? So we'll just give a sense of what's on the horizon for us as we move into the final steps of the updated guidance. And And just before we kind of get into the meat of the presentation, I want to say that I'd love to hear your questions as they arise. I know that with 40 people on a webinar in multiple locations across the globe, it's very difficult, but I am hoping that we can use the chat box function. So I'm going to keep an eye on the chat box. And if you have questions, please type them there, and then we can make sure that we build in the Q&A into this process as we go along. Next slide. And one more, next slide. So first, I think everyone probably on this webinar understands why health is such a critical service for survivors. But we just want to highlight some key facts that we understand about why health systems make such a crucial difference. And the first is that women and girls experiencing violence are more likely to use health services. So they're coming in for care already. And so therefore it's a really good entry point for meeting their needs and for making sure that we're reaching this key population. The second thing is that healthcare providers are often women's first point of professional contact. So we know that women don't disclose violence very easily, and that if they do tell someone, it's likely to be a family member or friend. But after that, when they seek a service, often it is a health service. And the reception and the care that they receive is determinative of whether they come back, whether their health needs are met, and just what the overall impact is going to be on their health and well-being. And the third point is that all women are likely to seek health services at some point in their lives. We know that the prevalence of GBV worldwide is incredibly high. We've seen that approximately 1 in 3 women will experience physical and or sexual violence by a partner or non-partner in their lifetime. And so if they're coming in for health services, this can also be really an opportunity to understand what's going on with them, what might be driving poor health outcomes. If violence is an issue in their lives, making sure that we address it within the health service and in referring a survivor to other potential services that could promote their health and well-being. Next slide. So I'm going to turn it over to Ann now to talk us through a little bit what the background was to the clinical management of rape survivors. It's been about 15 years since we've done an update last, and Ann can tell us a little bit more about what the purpose of this guidance was.
Okay, thank you very much, Elizabeth. So maybe just to give background, I think many of you, if not most, will be familiar with the Blue Book, Clinical Management of Rape Survivors, developing protocols for use with refugees and internally displaced persons. This came out in 2004. It was a joint publication between WHO, UNHCR, and UNFPA. It has that, the version at that time in 2004 was the result of several years of field testing of an earlier version, and it was finalized in 2004 with updated protocols at that time, and also with feedback based on the field test. So the main purpose of the document was to provide step-by-step guidance for best practice in clinical management of rape survivors. And it was aimed at nurses, midwives, and doctors working in field settings. It was, at the time, it was, subsequently there was an e-learning program that was developed. This was a self-instructional interactive program that was based on the content of the guidance and also based on training materials that were developed for field-based face-to-face training. So this is the background to the to the current version. Next slide, please. So it would be good to hear from you. Firstly, just two questions. To what extent is the current clinical management of rape survivors guidance known and used in your context? And secondly, what changes did you feel were needed to improve care for survivors?
And please feel free to use that chat box. We're going to give you a few moments to type in some of the responses so we can hear from you. And just to say, you can locate your chat box on the right-hand side right after attendees. Okay, so some more guidance on supporting clinicians on consent. Great. Thank you, Sarah Martin. More guidance on male survivors and child survivors. Great. Yeah, we're going to talk about that today. Medical certificates. It's really good for us to hear because we're going to talk through the process for the update. But already this is echoing a lot of what we've seen in our consultations. Conflict with drug dosages. Great. We will we'll talk about some of the updated treatment protocols, but also if that's not kind of what you're getting at with that question, please let us know. Disabilities. Here we have a comment that's very used. It's the most important reference for clinical staff and also for policymakers. So really looking at updating a few points around mandatory reporting and virginity testing. Great, thank you, Sani. Links to other services and HPSS. Yes, this is quite key. And also something that was very much echoed in our consultations. Detailed info on forensic evidence collection. We're going to talk about that because there are some changes on forensic evidence collection, so we will get into that a little bit more. Great, so this was just to get the conversation started. I encourage you, continue to chat your questions into the box or any comments that you might have. It's really, really helpful for us as we go on. Safe abortion care. Thank you, Sani. Yes. Can we move to the next slide? Okay, so why update? One, because it's been a while. So we've had a certain passage of time, which meant that some of the new guidance and evidence just was not reflected in the clinical management of rape survivors. Some of the treatment protocols were a bit out of date. So there were some kind of nuts and bolts things that we needed to do to make sure that the clinical management of rape survivors was aligned with the latest evidence and recommendations. But also there was new interagency learning. The field of gender-based violence work has really expanded since the last iteration. We have 15 more years of experience and practice. We've heard so much more from people who have used the CMR tools and guidance to improve health services for survivors. And so we really want to capture some of those key points, many of which are the ones that you're echoing in the chat bar. And some of those that have to do with certain gaps that we are seeing. In particular, some of you noted gaps around not just within the clinical management of rape, but also within looking at other survivor groups. So intimate partner violence was a specific area that was highlighted for us, where we're seeing that IPV survivors were seeking services, And so that was a need of health providers to have more clear guidance on this. And also there's just an increased recognition that IPV is an issue in conflict and in crisis. I think for a long time, the focus of GBV interventions on the health side were on rape. And, there was more recognition that there were other forms of violence as well that were really having health impacts during crisis. And then the second gap that was really highlighted for us was the one that was already spoken to around mental health and psychosocial support. Really seeing this as it was addressed in the original guidance, but we had more up-to-date guidance that we could use to supplement and really build that out more. Two kind of key pieces of guidance that we looked at. One was healthcare for women subjected to intimate partner violence or sexual violence, a clinical handbook. This wasn't developed for humanitarian settings per se, but it had really good guidance on intimate partner violence and MHPSS that we could use to update the CMR guidance. And the second one was strengthening health systems to respond to women subjected to intimate partner violence or sexual violence. Next slide. So the updating process, I think, the idea for an update probably dates back at least 2 years, maybe even longer. And it really started with a review of new guidance and evidence. So we did a very internal look at what exists out there, both from WHO and others, and to see how aligned the original clinical management of rape survivors was with this new guidance. We then reached out and did informal consultations. So we spoke with health providers and health actors through the Global Health Cluster and through our own networks to see what you felt were the gap areas and the things that really required honing to provide a better service. We also reached out to those within the GBV community, so we held informal consultations with the GBV AOR, who really was very helpful in saying, we do need to strengthen those connections between service providers, and that would be really helpful for both GBV service providers and health providers. We then decided on to develop new chapters. And so this is a point that we'll emphasize throughout the webinar. A lot of the core content remains the same, but we have added new content as well. So there are additional chapters, and I'll get into that in just a moment. So we put those in and made sure that they were adapted to the humanitarian space, just to make sure that we were really kind of honing in on emergency needs. And then finally, we did an external review. We engaged, I think, around 20 experts across 10 organizations and agencies to review the guidance. And here, I just want to highlight that, this is an update, not a revision of guidance. So it means that there aren't substantive changes. The updates are already reflected in existing guidelines on addressing rape and intimate partner violence. This is a kind of key point for many of us. The revision process for guidance is quite long and quite extensive, and it's quite possible that we will undertake that in the future. But for the moment, we needed a way to make sure that we were at least refreshing and updating the clinical management of rape survivors through a less intensive process that would still address the key needs. But it also means there's nothing radically different from what's out there already. Next slide. So we're going to go through the main chapters, and here, please again chat in the chat box, because we're going to go through each section one by one, and I want to hear from you what your specific questions are, because we're going to provide a broad overview, but not get into the details of what the different steps are, or exactly like the nitty-gritty of each step in the updated guidance. But I'd still like to hear from you if you have any questions or concerns, and if it resonates, if you feel that this is useful guidance. Next slide. So the CMR IPV, so the Clinical Management of Rape and IPV Survivors, has 6 chapters now. The first chapter is on preparations, and this really looks at what is needed to prepare to provide a service, a health service to survivors of rape and IPV. The second chapter is on first line support. I'm going to get to that in just a moment. The third is on clinical management of rape, so it's still the step-by-step that was in the original, with some slight modifications. The fourth chapter is now on intimate partner violence, so really dedicated to that. Then we have a chapter on child survivors, which is very similar to the original. In the original, we had the CMR and the child survivors chapters. So those were updated, those were existing content that were updated and remain in the new version. And then the final is mental health and psychosocial support. Next slide. So first line support. Maybe you could give me a sense if you're familiar with the term first line support already. If you could just say if you've heard of it before in the chat box, just so I can get a sense of how common this terminology is in the humanitarian sphere. Okay, have used in trainings, yes. Great. So we're seeing some folks who, actually quite a few who have heard of this term before and have used it in their own work. So the first line support is really the support that you provide. It's the first thing that a health provider does, and it addresses practical, emotional, material, and safety concerns. It's very consistent with psychological first aid, but it is adapted to some of the unique needs of survivors. And so it involves really 5 key components. The first one is listening, listening closely with empathy and no judgment. So kind of a bedrock, or the very first thing that a health provider needs to do. The second component is to inquire about needs and concerns, and then validate experiences, really showing that you have survivor-centered attitudes, that you believe and understand the survivor, that you are there to provide compassionate care. And then the final 2 elements are enhancing safety. So really looking front and center at some of the unique safety concerns that survivors face and that health providers can help address and mitigate. And then the final component is supporting survivors to connect them with additional services. So this really gets at one of the comments made earlier, that we really need to be strengthening the way that we connect survivors to other forms of support. One of the things that we've heard from health providers in trainings is that survivor needs can seem quite overwhelming, and that this can make it seed a little bit of reluctance sometimes to work on the issue, or just make a health provider feel really just overwhelmed in the moment. And so one of the key messages in the updated guidance is to really point out that there are other forms of support available, that we can tap into a network, and that health providers, there are concrete ways that they can make sure that survivors are connected to other psychosocial support services, other protection services, etc. So I'm going to stop there and just see if there are any questions on this before moving on to the second chapter. Great. Next slide. So the second chapter, or the third chapter actually, is the clinical management of rape, the step-by-step. The previous steps were 8 steps. The newer version, the updated version, also is 8 steps. They are largely the same. You start with, the first components of first-line support of listening, inquiring, and validating. You have, similar to the previous version, steps around preparing the survivor, obtaining informed consent. So also speaking back to a comment earlier about how to strengthen the guidance on informed consent, you will see very explicit guidance in this. The taking of the history, and then performing the physical and genital anal exam and providing treatment. So a lot of this is very similar to what was in the last version. And really, I don't think there's any content changes in this part. The final 3 steps are about enhancing safety and referring for support, assessing mental health and providing psychosocial support, and providing follow-up care. So here you'll just see that where in the past we had a step on counseling the survivor, we've now divided this out and made it a little bit more robust, and also are using more of kind of the terminology we use in humanitarian spaces now around MHPSS. Next slide. So some things that are key updates. You might notice that in the last, in the CMR from 2004, there was a step on forensic evidence collection. So this was, I believe, step 4 was collect forensic evidence. We still have the same information on forensic evidence collection, so we still have the same level of detail around the guidance, but it's not a step any further. It's a consideration that we flag in performing the physical exam, because this is where you would do the forensic evidence collection. We recognize that forensic evidence collection is often not available, and we really didn't want it to be seen as a barrier to care when survivors, when health providers weren't able to provide forensic evidence collection. We didn't want them to feel that they can't meet the health needs of the survivor. So we really wanted to make sure that that wasn't going to be an obstacle. We also wanted to emphasize that even when you can't do forensic evidence collection, there's often a really good role for good documentation, that can also be very powerful. It is more available in humanitarian settings. So you'll see an increased emphasis on good documentation. So now the forensic evidence is a bit split. You have a consideration in the step on the physical exam, and then you have an annex where you have all the full information on how to do forensic evidence collection. And then the other update that is, maybe a little bit more evident is the treatment protocols have been updated to latest evidence. We now have slight changes, very modest changes in follow-up. So I think in the last CMR, you had different follow-ups for if PEP was being administered versus wasn't being administered. Now we have follow-up at 2 weeks, 1 month, 3 months, and 6 months, regardless. And you have more emphasis on referrals, psychosocial support, and safety. So we're going to talk a little bit more also about the guidance on male survivors and on children, but I want to stop there and see if there are any comments or questions on what has been changed or updated within the step-by-step. And please, as always, just use the chat box tab, right? I'm going to take this as a sign that the updates are welcome. I'm going to move on, but please, if you need me to go back to a prior slide, or if you have any comments on the updates in this section, please just type them in and I'll stop and make sure to read them out and address them. Next slide. So we wanted to highlight what is in the CMR on male survivors. And I just want to say, first of all, that the CMR has always addressed male survivors. That's always been a part of the guidance. And so Some of the questions in the update were, are there any gaps around that, that we have guidance that exists already that can fill that gap? And how can we highlight a little bit better? Because we've heard quite a few people ask about what is the guidance for male survivors, which made us think that maybe it isn't sufficiently highlighted within the guidance for people to easily find it and recognize it. So some key points here. The updated guidance does acknowledge that men and boys can or may also be at risk of rape. So male survivors are quite clearly flagged within the clinical management of rape steps, and boys are included within the chapter on child survivors. So this is very clearly said in the guidance. There's an emphasis that the role of the healthcare provider is the same for male survivors, and that and that survivor-centered compassionate care and first-line support, they remain critical. No matter who the survivor is, those are kind of bedrocks, and that the way that you interact with the survivor is really important for how they receive the care and what their emotional and physical well-being is after they receive the health service. So we really wanted to emphasize the importance of the healthcare provider's role in that respect. We did note that the physical effects may differ somewhat, and adjustments are noted in the physical exam. So while many components of CMR are the exact same for men as they are for women, there are, of course, slight adjustments, and they're highlighted within each step. Most notably in the physical exam step, you'll see some concrete actions there. There's some others also when you're looking at, preparing the preparations for the service, and some of the considerations that might be impacting the way that you give first-line support. We've also included a little bit more noting that you have to be aware of laws and norms that may impede survivors accessing care. And so obviously some of the issues for all survivors would be around any mandatory reporting requirements, but that there might be criminalization of same-sex relationships that are posing a specific barrier to male survivors. And then, we have more on the need to identify referral options for more targeted support to different types of survivors, particularly sexual and gender minorities. So flagging that a little bit more in the referral pathways, the referral charts. Again, so I just want to check in. Please type if I know a lot of you said that this is something that you wanted to hear more about or that you hope to see strengthened in the CMR. I'm curious to see, does this address some of your concerns? Are there still things that you have questions about? Did you see this as a welcome change? Any question, really? I'm just going to wait a few moments to see if you have any thoughts before moving on. And I see that new attendees are arriving, so it's excellent. Yeah, we're up to 55.
Elizabeth, there was a question from the GBVAOR on the conclusion about offering male or female service providers. And then we also, I was too slow to type, but to expand more on the MHPSS or the psychosocial support referral links and maintaining survivor-centered.
Great. Perfect. So I'm so glad we got the question about the male or female service providers. So we didn't, obviously we're not making a concrete recommendation on what the gender of the service provider should be. We do note that female service providers are also most often wanted by male survivors as well. And so we indicate within the guidance that there's often this preference for female service providers and that there should be female service providers available to work with survivors, but that you would need to, that the key issue is to ask the survivor what they want and make sure that you have a health provider on hand. So really letting the survivor determine what they want to see from their health provider. Do they feel more comfortable with a man, or do they feel more comfortable with a woman? And then yes, there is some on the MHPSS. I mean, I think there are some concerns that male survivors might have about what this about what the violence means for them, for their identity, for their sexuality. So we do flag some of those. I will say that the mental health components are quite short. This has always been a very short piece of guidance, and we wanted it to remain so it can be very practical, but we have flagged some of those specific concerns, yes. Great, next slide, please.
Sorry, Elizabeth, there's just one question. Please expand more on the point of beware of laws and norms.
Yeah, so in preparing the service, in the first chapter on preparations, we talk a lot about understanding what the legal environment is. And this is very much from the original as well. Make sure that you are aware of whether sexual violence is a crime or intimate partner violence is a crime. Make sure that you're aware of what protocols are in place. And then, what are the norms around reporting? In some countries, especially if it's a country that has criminalizes same-sex relationships, if a man is raped by a male perpetrator, that can be a point that inhibits them from accessing care. So being really aware if that is the legal environment so that you can adapt the services to address that. Similarly, we see long-standing issues around mandatory reporting for women who are survivors of intimate partner violence or even of rape. And in those instances, healthcare providers also have to be aware of what their legal obligation is to report so that they can build it into the informed consent process, so that a survivor is aware that when she comes and seeks support, that these are kind of the limitations, and so that a healthcare provider can also still address health needs and medical needs, even in those contexts. So hopefully that gets your point. And then I see a last comment here, very welcome additions. Health-seeking behavior might be very different. Yeah, I would also flag that there's a lot that in doing this update, we were pulling from existing guidelines and guidance, and in doing so, we located a lot of areas where we don't know. And so sometimes this was also a process of uncovering where there might be an absence of guidance. So, very important point, one that we would like to learn more about. Okay, next slide. So we maintain also a chapter on child survivors. And here really looking at what are the guiding principles for that work. How do you do child-friendly communication? How do you create a safe environment for a child? What are the particularities of obtaining informed consent? And then, of course, how to conduct the physical exam and provide treatment. So here, a lot of this was already there. We made updates as needed, and we boosted the guidance with what we know more today around child-friendly communication and creating a safe environment. So we really did a lot of consultation, of newer materials on this issue to really to expand a little bit that important piece about how is a child survivor just gonna not only gonna have their physical health needs met, but how are they gonna feel safe and accepted, and how are they going to meaningfully access the service. Next slide, please. And I'm just seeing something in the chat box. Great update. Please put emphasis on support to adherence to ARVs. In challenges that you're facing around discontinuation of treatment. Yeah, this is a really great point, and I will say that we are at the same time trying to update our training materials because this is one of those issues that's come up a lot in comments, where these are some of the challenges you're facing in the field, and one that we really would benefit from some time and attention in training materials. So thanks so much for that. It's really helpful. Next slide, please. So moving on to intimate partner violence. This is really exciting for me personally. I've been just really felt that there's a need to have more guidance on intimate partner violence, and so excited to see this in the update. We have 6 steps. We wanted to use the same step-by-step format that we use for the CMR chapter. People really seemed to feel that that was helpful in making the guidance very clear, concise, and simple in some ways. So again, starting with the importance of first-line support, step 1 is listen, inquire, and validate. Step 2 is identify whether she may be experiencing IPV. And here on this point, I just want to address some of the issues or questions maybe around screening. So as many of you may know, WHO does not recommend universal screening. What is recommended is building in questions around IPV into clinical inquiry. So what the guidance does here is it tries to help health providers understand what to do if they suspect a survivor may be experiencing IPV, and how in a very supportive way to build in questions to move a little bit further and see if that is in fact the case. So this is how the approach to the second step is. If you're familiar with the clinical handbook, this will seem very familiar to you. The third step is providing physical care. And then step 4, enhancing safety and referring for support. Step 5, these are also kind of very similar to the CMR steps, assess mental health and provide psychosocial support. And then the final step, documentation of the visit. On obtaining child consent, I'm sorry, I'm just going to read a quick question here. On obtaining child consent, is there a provision for unaccompanied minors? There is a question around older children, and I think that there might be mention of unaccompanied minors. I don't want to misspeak, so let me follow up and see if I can reply to that later. We have clinical and policy guidelines on care for child and adolescent survivors, and we pulled from there. The issue of consent was very lengthy. So we took some of the kind of key snippets of that guidance and then referred to the full policy guidelines for kind of more in-depth information. And then we're also seeing a question on emergency contraception for adolescent who hasn't started. I'm going to have to follow up on that one as well. I know that it's quite clear. Let me check that and get back to you. Good questions here. Thanks so much for all of these. So on intimate partner violence, those are the 6 key steps that we were looking at. On assessing mental health, is there guidance on what to do if no referrals are available? Okay, I'm going to get right into that because that's the next slide. So if we can go to the next slide on mental health. Okay, so within mental health and psychosocial support, one, we are talking about the role of the health provider. And so here we're kind of asserting that the health provider has a key role to play in MHPSS, in building basic psychosocial support into the way they provide care to a survivor, in providing information about normal reactions to traumatic events. Because what we saw, or what we were hearing at least, was that it can feel quite overwhelming when a survivor presents and has very vivid emotional reactions, and it's very hard for health providers to determine if they need a specialized mental health support or if this is a normal reaction to violence. So we're trying to be a bit more clear about what is that role of providing basic psychosocial support support, and when might you have to assess for a potential mental health condition. And the 4 that we're looking at specifically are depression, suicide and self-harm, post-traumatic stress disorder, and unexplained somatic complaints. So here, I want to just go back to, is there guidance on what to do if there is no referral available? Here, what we're really looking at is the MH gap in humanitarian settings guidance. We are seeing that, you know, there are ways that we can support health providers to provide increasingly advanced levels of care to meet the mental health and psychosocial support needs. I think it's probably still a question of how you plan and deliver the service. If there is no referral available, how much you really want to kind of build into the role of a primary healthcare provider. There is guidance on that issue within the MH gap. We don't necessarily address it full on within the updated CMR IPV guidance, but we do kind of outline what the mental health needs could be, ranging from normal reactions to violence, the role of basic psychosocial support, and then how to really understand if something deeper, a mental health condition might be at play. I'm seeing another question about what about providing referral for IPV victims? Just curious, can you tell me a little bit more about that question? Referral for what type of service are you looking at for the IPV survivor? I'm also just going to take a beat here to, I know we've gone through the IPV and the MHPSS. I'm sure there are plenty of questions because the guidance gets quite detailed. So, you know, also if you have questions about anything that's been presented so far. Yeah, so is IPV targeting females only? All statements point at she and her. I suppose this may occur to males also. Yeah, so we have a bit of an explanation of why we focus on women, particularly within IPV. An acknowledgement, of course, that men can also experience partner violence, but what we find is that the violence is less frequent. It has less harmful health consequences most of the time, and it doesn't necessarily operate on the same kind of continuum. It doesn't have the same structural underpinnings. And so concretely, if you're seeing someone with a health consequence from IPV, most of the time you're going to be seeing a woman. And then the question about the referrals for legal and social support. We have, yes, we are using a referral framework where we look at what legal and social support is available. So we do look at kind of providing the referral to an external service. Also, you will see in first line support a heavy emphasis on trying to work with a survivor to see what type of social support exists within her own networks already. And this is really out of recognition that legal services might not be available, and police services, if they exist, might not be safe. So really seeing how you can emphasize the good supports that someone has already. Great to see this chapter on MHPSS. Are the IASC MHPSS guidelines referred to in this chapter? Yes. So we have, we did work with our own WHO's internal and mental health experts. We also reached out to the co-chairs of the MHPSS working group, and we do refer to the MHPSS guidelines. There is a pretty extensive key resources section, and so we wanted to make sure that this is quite consistent with what is existing already. Okay, next slide. All right, moving into what's next. Very exciting time. And just, keep coming with the questions. We'll try to answer them as best we can. I'm making notes of the ones that I was not able to answer so I can get back to you. And just to say, I really see questions as a form of enthusiasm. So very, very excited to see all the engagement with the guidance. And really, this is just kind of the first step. We are just kind of fresh off the presses with the guidance right now. So we're going to be doing more targeted dissemination and rollout in coming months. Next slide. So what does that look like specifically? So some of that we know and some of that we don't know. We are aiming to launch by summer 2019, so just in a few months. Right now we've committed to translating the guidance into French, Arabic, and Spanish. Which we felt would be very helpful in making this field relevant. So that is kind of a first priority to also do that in the next few months. And then WHO, UNFPA, and UNHCR have been looking at how we can do interagency rollout. What is kind of the need for webinars like this, just to alert people to updated content and cover some of the basics. Where can a workshop really help us get into those really good questions you've been asking about the nitty-gritty of the content? And what other events can we do to really maximize awareness about this key resource? What I've been hearing quite a bit are that this is a foundational document when you're working on GBV from the health side. And so how can we make sure that these exciting new updates are shared as broadly as possible? So there's two more questions. Access is limited to IPV survivors in closed societies. Does the guideline allow for community-based medical care? Any guidance? Really great question. I think that for now, we aren't addressing how the care is provided. We're addressing mainly what the elements of care are, if that makes sense. So I could see, as we start to roll this out, and particularly when it comes to IPV, because we haven't necessarily been addressing IPV in a consolidated way, that we're going to identify more needs for more guidance or more capacity development to address issues like the ones that you're discussing. It's really helpful for me to see what those issues might be. But I would just say from my own personal perspective that I could definitely see a lot more work going into the IPV care, just because it might be relatively new and it might be an area where we really need to consolidate what is emerging as really good practice. Are there any plans for regional rollout? Yes. So just to say that all our three agencies have regional focal points, and we don't want to keep this here in HQ at Geneva. We are probably looking at rollouts in the Middle East, in the African region. We're going to try to identify where there's most need, but we definitely don't want it to be limited to Geneva level. How can we help with rollout? Many of us are engaged in various working groups on various levels. How can we collectively support rollout? Thanks so much for that question. I think, the way that this webinar came to us is that the IAWG knew about the updates. They gave us the platform, felt that the membership was really going to be keen to hear about this. So if you similarly are with a working group that you think we should be tapping into, please feel free to reach out to either Ann, Nadine, or myself. We'd love to think about that more. Right now, I think when we develop our dissemination plans, we're going to do a cast an eye at what is existing out there. Obviously, I sit within the global health cluster, so really looking at the health cluster, looking also at other kind of GBV-specific fora to see how we can really maximize the rollout. So we will be doing that for sure in strategizing, but please reach out to us. We'd love to really spread the word, especially once this is printed, because we'll want to be sending it out. Is it possible to share these slides so that we can start engaging staff in our country offices on these updates? Yes. So I will be working with Maria and Dabney to circulate the final version of the slides. We just have to make sure it's signed off on at our levels. And then, yeah, please feel free to use these with your country offices. We're really excited. And we can also provide more information on who might be available from our agencies in country to support you. We have just started to discuss possibility of a WHO UNFPA rollout for West and Central Africa. So that's Maria Katerina Ciampi, who is the GBV officer for WHO in the Africa region, talking about some of the regional rollout efforts. Next slide. Yeah, so please send us your thoughts on dissemination and uptake of guidance. I see we've got a good discussion already. We have here the contact information for Ann and myself and for anyone involved in the project, so we would love to hear from you. Just seeing some more comments, just want to add that many people joining is from GBV AOR community practice. So a great example of good collaboration. Yeah, absolutely. Thank you so much. I know that there has been a lot of spreading of the word within the community of practice and with the GBV community. So we definitely want to make sure we keep those links alive. So thanks so much for all of that. Did you say the recording would be available? So yes, I think Maria can follow up on the recording and on the slides. I see quite a few comments. I'm not sure if I'm going to have time to get into all of them. I'm going to, because I think there's still some updates from the IAWG. So I'm going to stop here and then hand it back to Maria to walk through some of the other updates that are coming. Thank you so much.
Thank you so much, Elizabeth and Ann, for taking this time. Just to clarify one or two of the questions. Yes, we are recording, and our plan is we will circulate this first to Elizabeth and Ann just to get their sign off, and then it will be put on to the IAWG website in some way, and we will also circulate this. This is beyond my capacity technically, so I'm trusting that will work somehow. But that is, yes, the plan. So we are hoping that our friends from the GBV community of practice can find their way to the IAWG website when the recording is up. We actually are close towards the end, and I just wanted maybe to open if there's any updates or anything that any members would like to share. You can write in the chat box or unmute yourself and speak. I will be quiet for a second so that you can get your thoughts together before we close. Silence. So I just wanted then to update the full group that, as you know, there's a GBV pledging conference in May in Oslo, hosted by UNFPA, OCHA, and the government of Norway. And there will be a civil society day on the 23rd of May, and then it will be followed by a high-level day on the 24th of May. And we will be hosting a parallel session specifically on SRH, or linking SRH and GBV. So this would be I will reach out to Elizabeth and Ann to see how we can incorporate some of this into that session, but we're also open for suggestions from anyone from this group. I'm sure you've heard about this event. I will also take this opportunity then just to, on behalf of IAWG and the GBV AOR community of practice, to profoundly thank you, Ann and Elizabeth, for taking the time to present these updates. And it's really encouraging to see how we are getting now more and better guidance to really facilitate our work and reach those that need it. And we see great this as a great companion to what the SRH sector is working in the Interagency Field Manual on Sexual Reproductive Health and Crisis, including the MISP, and linked with the GBV handbook coming from the GBV AOR, and also just using the gender handbook from the Interagency Standing Committee and those that are coming on disability. So we're seeing a lot of good guidance coming out, and we look forward to working collectively as a community on rolling this out to those that are in the field and providing the services. So on that note, for me, it's 9 o'clock p.m. I'm not sure what time it is in your worlds, but I would like to profoundly thank you all. And unless there's anything anyone would like to say, we will close this webinar now. Thank you very much and have a great day, evening, morning.